Okay, so good afternoon. And I'm here today to present the seminar that will be held by Dr. Luca Di Tommaso in the frame of the newly appointed faculty member seminars. Dr. Di Tommaso graduated in medicine and surgery at the University of Bologna, and he did his residency there in pathology. And after getting his specialization in pathology, he moved to Humanitas Clinical Institute in 2003, where he's a staff pathologist in charge particularly of cytology and breast, thyroid, and thymic pathology. He is assistant professor of pathology since 2012, and he spent the first almost 3 years at the University of Milan, and then he moved to Humanitas University in October 2015. He is author of more than 70 papers on international peer-reviewed journals, and his main research interests have focused particularly on the phenotypic and molecular characterization of pre-neoplastic and neoplastic lesion of the liver, thyroid, and breast. Today he's going to give us a lecture that will represent the natural extension of the seminar that was held by his mentor, Professor Roncalli, a few weeks ago, which is entitled, as you can read, From Puzzle to Patients, the Role of Liver-pathology in the Translational Era. So I'm happy to give the stage to Dr. Di Tommaso for his talk.
Good morning, everybody. So I would like to start my talk with these paintings which represent Bologna at the end of the 13th century. Bologna at that time was known as La Turrita, which means a town rich of a tower. And most important, it was known because in Bologna the first European university was created exactly at that time. And at its very beginning, it was a university focused on law, but soon after, many other schools developed, and one of the most important is the School of Medicine. And as you probably can understand by your own, since you are at the very beginning of medicine, at that time, the main focus of research for a medical school was anatomy. And that person over there is one of the most important teachers of anatomy at that time, Mondino de Liuzzi. He also wrote a paper which is illustrated there. The original name was Notomia, not Anatomia, but anyway. And if you are going to visit Bologna, and I strongly suggest this to you, you can still see the famous autoptic room with all these skeletons made of wood on the back. So, as Prof. Duga told you, I graduated in Bologna, and then after my residency, I moved here in Humanitas. It was 2003, and that pictures belong more or less to that time. So here I met the group of Prof. Roncalli, and as you probably heard if you attended his lesson at the end of December, he was born in Bergamo. And here is a picture of the upper part of Bergamo, Bergamo Alta. Someone is showing a joy up in the public. And I think that Prof. Roncalli developed his interest in puzzle and patchwork, and he was talking about puzzle and patchwork, and I will do the same, in that church over there, which is Santa Maria Maggiore, which is not the cathedral of Bergamo, but is a famous church in Bergamo. Indeed, if you go and visit, again, this is a suggestion, you will find such type of picture, which is a picture made by small pieces of wood of this different color put together to give these final results. The name in English should be inlay, intarsio in Italiano. And I think he developed this interest for puzzle looking at this image, in particular in this one, which has been created by Capoferri and drawn by Lorenzo Lotto. You can see an episode of the Bible, which is Giuditta, with the head of Oloferne. And in the back, you can probably see Bergamo, put there by the author. So I think that these inlay are very similar to pathology, since they are made by small pieces of wood of different color, different shape, and you have to put them together to create an image. At the very end, pathology is something similar. You put different information together, and the final result is a diagnosis. And then our duty is to give the diagnosis to the person who are in charge of patients affected by liver pathology. And these are 4 colleagues working here in Humanitas who are exactly in charge of this. Okay, so Prof. Roncalli presented you the story of liver pathology as a puzzle. So why don't we play this game together just for 20 minutes? One of the questions usually asked us by clinician is the following one: is the lesion we are looking at an hepatocellular carcinoma? This condition, to be honest, in some cases is addressed by radiologists, not by pathologists. So especially the large cases, like this one depicted here, can be diagnosed by imaging. So pathologists play no role. But in a completely different setting of lesion, which are the lesions staying about 2 centimeters in size, the story changes completely. Indeed, imaging is not sufficient to make a diagnosis. And also epidemiology is not clear-cut between one type of the lesion or the other one. And the distinction between these 2 lesions is important because high-grade dysplastic lesions are advanced precancerous lesions, while early hepatocellular carcinoma are initial cancerous lesions. So you can understand by your own, even if you are at the very beginning of medicine, that the fate of these 2 lesions is completely different, and also the attitude of patient toward this is completely different. And this was exactly the point where I started working on my research activity with my mentor, Prof. Roncalli, in 2006. At that time, he was collecting lesions like this one, which is a vaguely nodular lesion inside a cirrhotic nodular liver parenchyma, and he was trying to evaluate on this surgical material if biomarkers coming from molecular studies, so from basic research, can be useful to diagnose this lesion. So if they can be translated at the bed of the patient. And these markers were, you can see them from the title, HSP70, glypican-3, and glutamine synthetase. And if you look at these neoplastic cells, they stained positive for these 3 markers. So we were lucky. We were able to translate these 3 markers in the clinical practice. And our hypothesis that we put in that paper, which was published in Pathology, was that if you are looking at a lesion which is doubtful at imaging, and the lesion is positive for at least 2 of these 3 markers, well, the lesion is an hepatocellular carcinoma. But when we were writing that paper, we thought about a problem, which is the following one. Once a patient has already received a surgical resection, an hepatectomy, he has already received the most he can receive. So the real translation would be to evaluate this marker on liver biopsy, so on biopsy obtained from the same nodule before surgery. Because according to the results of the biopsy, you can suggest the clinician to do or not to do its own work. So just to make an example, if the lesion is an hepatocellular carcinoma, well, surgery is appropriate. If it is an high-grade dysplastic nodule, probably surgery is not adequate. And we started working to this aim in 2007, and we were successful in 2009. At that time, we were able to translate our results from surgical specimen to biopsy specimen. And here is the example. You can see by your own that neoplastic cells are positive to 2 of these markers. And we went out with this hypothesis, again, also in liver biopsy. If the lesion, which is doubtful at imaging, stained positive for 2 of these 3 markers, well, it is an hepatocellular carcinoma. And the most interesting thing came later because another group, a big one working between Spain and the United States, convalidated our results, so validated our results. And so our results are currently endorsed in the diagnostic guideline of hepatocellular carcinoma in Europe and United States. It means that if you have a doubtful lesion, to be sure that the lesion is an hepatocellular carcinoma, should stain for 2 of these 3 markers. So with that research, we put in the correct place 2 of the pieces of the puzzle. 90% of hepatocellular carcinoma develop in the cirrhotic background that I show you, but 10% develop in a completely different setting, the setting of normal, so-called normal liver. So we try to apply our markers also in this setting. So we try to evaluate if they can be useful to distinguish adenoma, liver cell adenoma, which is the lesion supposed to give origin to hepatocellular carcinoma in this setting, and hepatocellular carcinoma. And the results we are publishing right now, the results are promising on surgical specimen, GS and HSP70 also in this setting seems promising, seems to separate hepatocellular adenoma from hepatocellular carcinoma. Talking about hepatocellular adenoma, I also would like to underline you again the significance of biopsy and biomarkers used on biopsy. We know now from molecular studies and histopathological study that hepatocellular adenoma can be subdivided in 4 subtypes. The classical one, the steatotic one, which is rich in lipid, the atypical one, which shows atypia, and the telangiectatic adenoma, which is rich of vessel. Well, we can say this on surgical specimen, but now, due mainly to the study of a French group, we have biomarkers which help us to recognize this lesion also on biopsy. For example, if the lesion stains negative for this marker, it is for sure a steatotic adenoma. If the lesion stains positive at nuclear level for beta-catenin, it is an atypical adenoma. If it stains for C-reactive protein, it is a telangiectatic adenoma. Where is the key point for clinicians, for doctors? The key point is that if you have such a diagnosis, you can predict the risk of malignant transformation. So again, this is an information for the surgery because, of course, it will treat mainly this one, which are at high risk of malignant transformation, and not this one, which have no risk to malignant transformation. So we think that also with this, we put some pieces in the right place. Going back again to the main, the classical human hepatocarcinogenesis, so that developing in cirrhotic background, we recently used our 3 markers with the addition of some more to identify this lesion, which stays in between high-grade dysplastic lesion, I told you the most advanced precancerous lesion, and early hepatocellular carcinoma, which is the very beginning of a cancerous lesion. And these pre-invasive ACC do express novel markers of malignancy, shown here, but they do not infiltrate. So they are pretty similar to the concept of in situ carcinoma that you will be familiar or you are already familiar. And we published this paper just recently. And a promising research is the following one, to use this marker as predictors of transformation. So we think that this marker and also a molecular mutation, Prof. Roncalli told about this in his lesson, since they are recognized in a high-grade dysplastic lesion, we think that lesion expressing these biomarkers or TER promoter mutation can be those transforming into hepatocellular carcinoma. And we are currently doing some research on this topic. Okay, let's go to another topic. Prof. Roncalli mentioned you about this one. I told that hepatocellular carcinoma can develop on a cirrhotic background, but once the patient already had an hepatocellular carcinoma and the hepatocellular carcinoma has been removed, is that lesion going to come again? So is it the cirrhosis background, a fertile soil to a recurrence? Well, at the end of 2010, this Japanese group published these interesting results about CHIP1, and they showed that the expression of this marker in the cirrhotic background, so in the cirrhotic parenchyma around hepatocellular carcinoma, is a marker of recurrence. In particular, those with high level of CYP1 will not develop ACC recurrence or will develop a recurrence later, as opposite to those which do not have CYP1. So CYP1 is normally expressed in hepatocytes, but in a damaged liver, the production of this enzyme is reduced. So since we think that biopsy is a decay in the translational aspect in liver pathology, we first try to evaluate if the study of the Japanese apply to biopsy. And so we first evaluate if the staining can be evaluated properly in the biopsy. And here is the image which shows clearly that the idea works also on biopsy. And then we did something more. We collected 3 different series of patients with 3 different background of liver disease, HCV related, so hepatitis C virus related, HBV, hepatitis B, and steatohepatitis. And we noticed that the story of CHIP was confirmed in our hand, but just in the setting of HCV hepatitis background, which probably means that the pathogenesis of the damage in the liver in the 3 setting is completely different. And this marker can be a marker useful to predict recurrence only in patients with HCV. And the paper here is under submission right now. So again, small pieces in the right place. And another question you will receive probably when you will be doctor in the future, this question from patients is, hey doctor, how is going my hepatocellular carcinoma? Will it develop metastasis? But also your colleague will ask you. So we started working on this item after this paper published in 2014 by another French group led by Valérie Paradis. And they suggested that PIVCA is a predictor of microvascular invasion. So we work exactly in the same way. We first would like to confirm if the marker is a good one, and it is a good one since the neoplastic thrombi are positive for PIVCA2 on surgical material, either as a strong staining or as a faint staining. And then we move to biopsy, since we think that this is important. Of course, we confirm the same results on surgical specimen. And on biopsy, we observed some problem, which is represented here. Some biopsy are positive but are faint, some biopsy are positive and strong, and some biopsy are partly positive and partly negative. So this can be a problem to apply, to use this marker on liver biopsy. But we also observed another interesting aspect, that moving from the original tumor to the first metastasis, to the recurrent metastasis, the expression of this biomarker increase progressively. So we are putting this information together, writing a paper, and we hope that in March 2016, the paper will be submitted, hopefully. So also this one can be a piece of our puzzle in the correct place. I told you that we are dealing with several colleagues, not only the surgeon, but we have also radiologists, since some hepatocellular carcinoma are not treated by surgery, but are treated by chemioembolization, so by embolization. And one of the questions of the colleague dealing with this is the following one. When I'm dealing with 2 tumors completely different, which one is going to respond to TACE? Well, we started working with this with one of your colleagues. Amedeo Sciarri was at that time a doctor, he was graduating in medicine here, and then he performed, this is his thesis. The idea is to investigate some marker related to hypoxia and to angiogenesis in 2 settings of patients, 2 series of patients. And we discovered at least 4 factors which were related to a good answer to TACE. But 2 of them, the diameter and the presence of the capsule, cannot be evaluated properly on the biopsy. So we went for the other 2, which are 2 immunohistochemical markers, which can be evaluated. So going back again to the idea of translation. And here is the point. We saw that in some biopsy, the CD34 was extremely positive, and another completely negative, and the same for the other marker, which was so completely positive in some cases and completely negative in other cases. And these two phenotypes were related from a statistical point of view to a not responder condition. So we put forward a scoring system, and it works. Patient with a score 0-1 built on biopsy obtained before treatment using the other two markers, the marker that I show you, respond properly to TACE, while those which were not responder on biopsy did not respond. And here is the paper and the first name, Amedeo Char. So another piece, and we are going to the end. Another condition is the following one. You have a large, huge tumor infiltrating the abdominal wall. Of course, this is not resectable, this is not treatable with TACE. So the unique therapeutic possibility that we have is sorafenib, which is the unique drug for this tumor. And so the oncologist is going to ask us if this lesion is going to respond to sorafenib. And in the original paper, phase 2 study on this drug, it was suggested that the patient with the expression of phospho-ERK will respond better to sorafenib. So we tried the same on a biopsy, and we observed that some cases stained strongly positive, some other were almost negative, and we observed that patients responding well to sorafenib were those with negative phospho-ERK. So exactly the opposite message from the original one. And this is to say you that in this lecture I show you very promising result, but in most of the cases, as Prof. Mantovani usually remember, the translation to the clinical practice of these markers is not so easy. Most of these markers are lost in translation. And doing with the same problem and using the same materials, so biopsy, we decided for a different approach. So we decided not to study phospho-ERK, but to investigate the expression of small RNA, here in the example of microRNA, and also from this point of view, we found something interesting, which is this mRNA here, and we observed that if the ratio of this mRNA between the ACC and the surrounding parenchyma was higher than 1, then patients are expected to respond to sorafenib. And the story of mRNA, of microRNA, is interesting since you can evaluate them on biopsy, but also on the liquid biopsy, so on blood. So quite promising for the future. And going to the end, and talking about small RNA, more recently, last year, our interest went on these PWIR interacting RNA, or PIRNA, and we investigated the profile of this PIRNA in some cirrhotic and ACC patients, and we observed that the two profile is extremely different, quite different as expected. But when we investigated the whole spectrum of the lesion, so when we tried to have an idea on the role of PIRNA on the pathogenesis, the story is much more complicated, of course, and we observed that there is a progression in the expression of this PIRNA. So each of these lesions is characterized by a fingerprint of PIRNA, and the paper is now under submission to Journal of Hepatology. So I'm going to my conclusion. Of course, this is Italy, and this is the puzzle I discovered with you. I hope you will enjoy not only our faculty here in Milan, but also Italy as a country is a country rich of town, but also is rich of history of many important persons. So I hope you will discover a lot also visiting Italy. And remember that research seems a story that ends, but once you think that you have put all the things, all the pieces in the right place, then another story open, another puzzle open. So this is the story of the research. Thank you very much for your attention.